Hello everyone and welcome to Indian Radiologist. Today I will be taking you on a tour of all the activities and programs that are scheduled for this year as well as for early Jan next year. We begin the Indian Radiologist section with the Journal Club. Now the Journal Club is a unique program that has been crafted out and created by Dr. Mitusha Verma as well as Dr. Gauri Ahuja. In this program, what we intend to do on the third Sunday of each month is that we take you through interesting articles that are coming about in the world of radiology. We will discuss them, we will dissect them, and also look at what options that journal gives us in our day-to-day radiology practice. This is a wonderful event, especially for resident doctors, because they get to present any article of their choice related to that topic, and we have exciting prizes in store. So the registration for this program is free but mandatory. So we would request you to just come onto our website and have a look at the Google form and just type in your name, and voila, you'll be part of the wonderful journal club that is going to start very shortly. The next program is the masterclass series. You know that we've had these wonderful masterclass series both last Sundays of a complete MSK overview. That again is a very basic fee, so we would request you all to join in for that program. The third program is post Diwali, and it is CT Buzz. So once again, CT Buzz this time is online, and hopefully this is the last CT Buzz that is online, and we hope to go on site once again. We have Sanrad as our chief sponsor for this event, and what we intend to do in CT is that we intend to make it a complete overview. So we're going to cover neck, chest as well as abdominal CT. So again, this program will have papers, posters, quiz contests, and the whole range of stuff that we always do. The last and not the least, of course, is Sonobus. So we've had two Sonobus so far. One, the on-site one in 2019 December, which was a great hit with more than 650 delegates. And then we had Sonobus Virtual this Jan, which had more than 2,000 delegates registering for the virtual event. This time we are going to go hybrid. So it's a mixture of both online as well as on-site event. And this is going to be in early Jan. This is Jan 8 to 9. And the details of this program will be coming up very shortly on our website. So stay tuned in with us, and we will be giving you more information on all these events very shortly. Thank you and take care. Bye-bye.
Yeah. Gauri, shall we start?
Yeah, Mitusha, please.
Hello friends, and we welcome you to this new initiative by Indian Radiologist. As Dr. Sanjeev Mani sir explained, the Radiology Journal Club. And this we are going to have as a monthly academic event online. And last month in the Sunday, we had neurology case discussions. We had two articles which we discussed, and the articles were shared afterwards. And also we had two cases which were discussed. We are going to improvise on the format as per your feedbacks and as per our expert suggestions. And today we present to you the second Radiology Journal Club, which is dedicated to breast imaging topics. And this we have with us the chief expert in the country about breast imaging, that is our own Dr. Shilpa Lad ma'am.
Thank you.
So the chief coordinator and the program has been designed completely by Dr. Shilpa Lal and helped by myself, Dr. Mitusha Verma, and my colleague, Dr. Gauri Ahuja, as well as Dr. Gayatri Harshe. And these are the core organizers of all these events of Indian Radiologists, and we are thankful for their constant support and guidance in spite of their busy schedule. Dr. Shailendra Singh sir, Dr. Jignesh Thakkar, Dr. Sanjeev Mani, Dr. Deepak Patkar sir, Shilpa ma'am, and Mamta ma'am. And we are thankful to all our education partners, specifically because without their support, these kind of events are not possible. And we would request all of you to spread the word around. The Journal Club is a new initiative and we want your feedbacks and support. All this will also be hosted on the YouTube channel by Indian Radiologists. So you can definitely go back and review and revise whichever part you want to. And even the articles which we are going to discuss and which we are going to see through, they are going to be shared with you so that you can review them later as well. So thanking Bayers for their constant support. And with this, the concept where we are going to discuss about the recent advances, recent literature, and see what all new is coming up, and also do a kind of short meta-analysis with our experts. You can also suggest if you have some cases to be discussed, maybe in the next journal club, we are going to include that part as well. And some of you can also participate in presenting these articles and journals. So last time we had these two articles on neuroimaging and interesting cases. And today we'll have a good discussion about another controversial topic in breast imaging. So let us start with the discussion. But before we go ahead, I would just request Shilpa ma'am to kindly guide us through the entire journal club to the way we are going to have it in the next 1 or 1.5 hours. And then we can start with the case discussion.
Thank you, Mitusha. Thank you for the kind introduction. I can do none of this without the constant help and support of two big pillars here for me. One is Mitusha Verma, other is Gauri Ahuja. The two people without whom we can do none of this is Dr. Deepak Patkar sir, Dr. Sanjeev Mani sir, and the two others who are in the background all the time, Dr. Shailendra Singh sir and Dr. Chignesh Thakkar sir. So I pay my due respect and gratitude to everyone here, and the one person, Dr. Gayatri Harshe, who has offered to discuss these cases without full knowledge of what the histopathology diagnosis is. So for her, it is an online viva. So thank you, Gayatri, for volunteering to be our taker of the case today. So what we are going to do today is we will show you a case, and as is the case with radiology images, when we see a radiology image, we think in our mind, I know the diagnosis, okay? Most often, after a few years of practice, we really do. But unlike mathematics, medicine is not always 2 + 2 = 4. Every once in a while, there is a diagnosis that comes in front of us, which is controversial, which means we don't know how to take the management forward. What should we do? Okay. And that is the kind of case we are going to discuss. When such a thing happens in medicine, what do? We go out there and we ask our colleagues, if you had a case such as this, how would you manage? When our colleagues say that this is kind of what I would do, the next best thing to do is go out there into the online world and find out what people are doing globally, nationally, literature, over the years, how people have been handling these cases and what their experience has been. So this is exactly the purpose of the Journal Club, to take up cases which have been challenging for us in our own practice and to read relevant literature to understand how best we can handle or manage these cases. So today we discuss one such case, and we have picked out on 2 articles which kind of tell us, you could go this way or you could go this way. Okay, so we want to bring it in front of the audience how we practice medicine. This journal club is meant to help us improvise our understanding of medicine, and also to make us understand why engineers go to work and do work, whereas doctors go to work and practice medicine, because we are constantly learning. Okay, so with that, I would request Mitusha to take us through the case, and I would request Gayatri to describe the findings on this case. And as a radiologist, what is it that she would expect to find in the diagnosis, and to take us through the differentials? Over to
Thank
you,
you, ma'am.
Vidisha.
Yeah, thank you, ma'am. And with this, now it's time to start. So we have with us Dr. Gayatri Harshe. She is a fellow at Nanavati Super Speciality Hospital with us, and she has completed her DMRD and DNB. So welcome you, Gayatri, and thank you for being there with us today. Let's start with the case. This is the short clinical history. This is a 44-year-old female with strong family history of breast and ovarian cancer. So as such, the person herself, she has no major complaints, just a very, very strong family history. So she came for a routine screening mammogram. And these are the mammograms which we have with us. And you may please start your description.
So these are the screening mammography images, mediolateral oblique view, and here what we can see, this is a optimal projected mammogram. We can see the pectoralis major in oblique convexity in the upper portion of the mammogram, and if we draw the nipple line, posterior nipple line, there is a asymmetry in the left breast, what we can see on these mammographic images. So I would like to see the craniocaudal view also.
So unfortunately, in this case, we did not have the craniocaudal view because some part of the imaging had already been done outside. But on the mediolateral outside, out of the city, in a smaller place, and we were not completely convinced that the images were of optimal quality. Therefore, 3D tomosynthesis and bilateral MLO views were repeated, and we saw some microcalcifications. Unfortunately, they are not projected well, so we went ahead and did spot magnification views.
So in this spot magnification view, I can see the a few pleomorphic calcifications in regional distribution. So these are concerning for neoplastic etiology. And there is actually, on the previous mammographic image, there was asymmetry also in this region. So I would like to do ultrasound for the further, and if it is needed, tissue sampling.
Let's look at the ultrasound image. So the one question for you before we go ahead, when we do spot magnification views, Gayatri, what are the views that we use for spot magnification? Do we use the CC and MLO view, or do we use the CC and ML projection?
CC and ML projection.
ML projection. Excellent, excellent. And is it just a digital magnified image, or are there any special prerequisites required for spot magnification views?
Ma'am, I actually don't know.
Okay, so I will explain that. This is a good point, and this is an area of confusion for a lot of resident and fellows. Therefore, this is something that we should bring up. Okay, so spot magnification views are done in two projections. One is the CC projection, and the second is a ML projection. ML projection means it is at 90 degrees. And why do we do that? Because if the calcifications are within the CIS, then on the straight lateral view, they layer out. Okay, but if they are pleomorphic and in a segmental or regional distribution, they will not layer out. So it gives us an idea whether we are dealing with a fibrocystic breast or we are dealing with something more concerning. Therefore, we obtain that ML projection. The second point is how different are spot magnification views from the regular views. Okay, we use a smaller focal spot when we do spot magnification views, and there is a standoff paddle that is used. Okay, why do we do that? Because it not just digitally magnifies the image, but it is a true magnification such that the resolution is maintained. And that resolution is important because we want to assess those microcalcifications. When we say pleomorphic or monomorphic, what we are trying to see is the morphology of those calcifications. Are they all uniform dots? Are they all dots and dashes? Are they V-shaped, Y-shaped? But to see that, we need good resolution. And therefore, we do spot magnification views with the standoff paddle and a smaller focal spot for optimal morphologic evaluation of those calcifications. So you rightly described this as pleomorphic microcalcifications. So when we describe microcalcifications, we describe first the morphology of those calcifications. Are they pleomorphic or are they monomorphic? Next, we describe the distribution of those calcifications. Are they in a linear segmental microcalcifications? Are they involving an entire segment? So pleomorphic microcalcifications in a segmental distribution. Are they involving an entire region, which means one whole quadrant? Are they pleomorphic microcalcifications in a regional distribution? So always go step by step by step when you're describing microcalcifications. Remember, just like the pilots, we are in an autopilot mode. But to get into an autopilot mode, we have to train our mind to get into the habit of going through the same protocol of reviewing and describing, so we don't miss out on lesions. Okay, so when I describe this, or when we describe this as radiologists, we say there are pleomorphic microcalcifications in a segmental distribution involving the upper outer quadrant of the left breast and extending to the base of the nipple areolar complex. Am I seeing nipple flattening? That also I will describe. I'm not seeing nipple flattening. There is no nipple inversion. And based on the mammographic views, I don't see any skin thickening. There is no nipple inversion. There is no skin thickening. However, there is an asymmetry associated with the pleomorphic microcalcifications. As soon as I say something associated with the microcalcifications, whether there is an asymmetry or a mass, I'm saying that I want to do some additional evaluation. And for evaluation of that, I would like to do an ultrasound for correlation. So you rightly pointed out that you would need to do the ultrasound. Okay, so far we have come up to here, and let's look at the ultrasound images now. So do we have, yes. So now on this ultrasound image, this is what we see in the right retroareolar region. Would you like to describe it, Gayatri?
Yes, ma'am. This is a irregular hypoechoic mass lesion in the same left upper outer quadrant, and there is a needle track also seen in this image.
In the previous image, this does not have the needle track. This is the previous image. Yeah, this, yeah, there is a needle track.
So there are two images. So this is the one where we don't see the needle track. So you can describe this one for the lesion characterization.
Yeah. So this is an irregular hypoechoic mass in the breast parenchyma.
Okay.
Without any obvious calcification seen on this sonography image.
Okay. So another pointer, like your description is correct, but again, we follow a protocol when we describe breast lesions, and we stick to Bairad's lexicon. In your mind, you go in this order. You know, what is the shape? There can only be three shapes. It can be oval, it can be round, or it can be irregular. What is this? Is it a oval mass?
This is an irregular mass.
Irregular mass. Then we go to the margins. What are the margins like? Are you seeing irregular margins? Are you seeing spiculated margins? Are you seeing angulations along the margins? Are you seeing microlobulations along the margins? This is how you go in your mind. Okay. What is the margin like?
So in this mass, there are few angulations.
Yes.
Not like actual spiculated lesion in this.
Yeah. So that's the correct description. You are seeing an irregular margin. It is not a smooth margin. It is not a smooth echogenic margin like you would have in, say, a fibroadenoma, or a smooth imperceptible margin like you would have in a cyst. This margin is what we describe it as irregular. And you rightly pointed out, there are also angulations. So if you were to draw a line, along the edge of some of the margins, you could actually make a obtuse angle or a right angle along the margin. So there are angulations along the margin. Okay. And are we seeing microlobulations? Not really. I'm not seeing a margin like a Monaco biscuit here. Okay. So these are the descriptors we use. Then we describe the echogenicity of the mass per se. What is the echogenicity like? Is it homogeneously hypoechoic? Is it heterogeneously hypoechoic? Is it anechoic, or is it echogenic? What is the echogenicity?
This is heterogeneously hypoechoic lesion.
Correct. So that becomes the second part. So three parts we have done. We have done the shape, we have done the margins, we have done the echogenicity. Now we want to see for any associated findings. Are you seeing any extension along the ducts?
There is an extension along the on the left side.
Yes.
So
there is intraductal extension too. And this is corroborating with what we saw on the mammogram. We saw tubular structures on the mammogram. There were microcalcifications, but this looks like there is a mass which is an irregular mass with angulations and irregular margin. It is a heterogeneously hypoechoic mass. Plus, there is intraductal extension, hypoechoic intraductal extension. So now put the two things together. Your description on your findings on the mammogram plus your findings on ultrasound. You saw pleomorphic microcalcifications in a segmental distribution, which is corresponding to this irregular hypoechoic mass with intraductal extension. So what is it that you would worry about? What would be your differential diagnosis in a case such as this?
Invasive carcinoma.
Invasive carcinoma. That is a good thought. Could there be anything associated, since you're seeing microcalcifications, could there be anything associated with the invasive carcinoma? DCIS. So every cancer would start as a ductal carcinoma in situ, which means the cancer cells are inside the duct. When it breaches the duct and it comes out, it becomes an invasive cancer. So two components can coexist. And that is what we are suspecting in case that the two components are coexisting. Of course, there is an irregular hypoechoic mass with intraductal extension, which is there. Plus, there are pleomorphic microcalcifications. So I'm thinking we could be dealing with an invasive carcinoma with associated DCIS. So in a case such as this, is there a differential diagnosis in your mind? Or you're pretty certain this is what it must be?
No, ma'am.
No, correct. Even my thought was the same. I didn't have any differential in my mind. This is book picture. There are microcalcifications. There is a suspicious mass. This needs a biopsy. We are dealing with an invasive cancer with DCIS here. Okay, so what should be our next step forward? So when we see a suspicious mass, what should we do?
Ultrasound guided biopsy or
Correct.
vacuum assisted ultrasound guided biopsy.
Okay, so this is a good point you have brought up here, Gayatri. What kind of biopsy should we choose in this case? Should we do a 14 gauge ultrasound guided core biopsy, or should we do a vacuum assisted biopsy? I can see why you think so, because you're seeing microcalcifications. Therefore, you're wondering whether you should do a vacuum assisted biopsy. That is a good thought. However, when you see a mass as such on ultrasound, then it is a good practice to go ahead with a core biopsy. A simple core biopsy will do the trick for you because you're already seeing a mass which looks like an invasive cancer, right? And our accuracy rate with a 14 gauge core needle biopsy for getting concordant findings is about 96%. So 96% of the times you are going to get an accurate diagnosis with 14 gauge core needle biopsy. Therefore, if you're seeing a mass on ultrasound, the easiest way to do a tissue diagnosis is ultrasound guided core biopsy with a 14 gauge needle. If this mass was absent, and if you had only seen pleomorphic microcalcifications and you did an ultrasound and you were like, thinking maybe there are calcifications here, maybe I'm not sure, then the best step forward would be to do a stereotactic vacuum assisted biopsy for the microcalcifications. Okay, but we always try to take the easy way forward first. In this case, ultrasound guided core biopsy, and that's exactly what we did. And Mitusha, can you share with us what was the diagnosis?
Yeah, sure, ma'am.
Atypical lobular hyperplasia. Now, what is this? I was suspecting DCIS with a full-blown invasive cancer, and the diagnosis has come as atypical lobular hyperplasia. What is the first thought that comes to your mind when you see a histopathology diagnosis such as this? What are you supposed to do? What is your role as a radiologist, Gayatri? First role as a radiologist.
Further, MRI can be performed to confirm this, and any other lesion in the means contralateral breast, that is also necessary for a treatment planning.
Okay, so this is a good thought, but before we do the MRI, there is one step that we are expected to perform. The step is to establish radiology, pathology, concordance or discordance, which means you have to first ask yourself, I was suspecting an invasive cancer with DCIS, but the histopathology diagnosis is showing atypical lobular hyperplasia. Do I agree with this histopathology report or not? That is the first question you ask yourself. Second thing you ask yourself is, if I do not agree with this histopathology report, then what is the next best step to do? Should I repeat the biopsy or should I do some additional investigations? Okay, so these are the two steps that have to happen after a biopsy is done. So my first question is, do you agree with this histopathology diagnosis? You were thinking DCIS, invasive cancer with DCIS, and this has come up to be atypical lobular hyperplasia. Is it concordant or is it discordant?
For radiographic diagnosis, it is not correlating with the pathological.
Absolutely. Absolutely. That's the correct answer. So what we are seeing on the mammogram and ultrasound is not fitting in with what the histopathology is showing. So we could do one of two things. Either we could repeat the biopsy, a higher grade biopsy, which is a vacuum assisted biopsy, or we could ask for a surgical excision biopsy. Okay. In this case, when we asked for a surgical excision biopsy, the surgeon said, hold your horses. Before I take this patient in for surgery, she's only 44 years old. I want to know what is the true extent. Will you guys do a MRI first? Okay. So more investigation is not a replacement for biopsy, but in a controversial situation, we can do a higher end investigation in the form of MRI, which is functional imaging. It is not just structural imaging, but it is functional imaging. So in keeping with that, plus given the fact that the patient has a strong family history, her mother had breast cancer, her grandmother had ovarian cancer, and one of her masis also had breast cancer, and she had died of breast cancer very early. So, but the patient had been reluctant to do BRCA mutation testing, genetic testing. So we don't know her genetic testing status. Okay, but she comes for her mammogram and screening regularly. Okay, so keeping all this in mind, we decide to go ahead with the MRI. And what does the MRI show us?
Yeah, ma'am. So as we know the story till now, we have got a histopathologic diagnosis, but now the big question is the assessment of the extent. And as ma'am explained, for that MRI was performed for this patient. So these are the MR images, and we have few sections which we have selectively chosen to show. So here you can see that, as ma'am said, it is a functional imaging and not just a structural imaging, and dynamic multiphasic post-contrast images were obtained. And we can see and appreciate that there is asymmetric non-mass enhancement in the left breast. And if we see on these axials and the sagittal projection, there is almost a near complete involvement of the entire superior sphere, superior half of the breast. So it's like the extent wise, it's quite an extensive large area which is involved, much beyond what was seen on the mammogram and even the ultrasound. So this is what MRI came up with, that the extent is really large. And whenever we are deciding on the treatment, the area which is involved, as it is quite large, it has to be probably mastectomy if it is surgical option. So that is the big question which ma'am will take us through and guide us through. So Shilpa ma'am, anything else you would like to tell about the MRI, and then we can take it further.
No, you described it very well. So what we are seeing on the MRI is, as compared to the right breast, the left breast looks slightly enlarged. And we also notice that there are multiple areas of asymmetric non-mass enhancement involving the entire superior hemisphere of the left breast. In fact, what we saw on the mammogram was just the tip of the iceberg. We only saw a few microcalcification. Even on ultrasound, we saw a small irregular hypoechoic mass, which was less than 2 centimeters in maximum dimension. But on the MRI, look at the number of foci of asymmetric non-mass enhancement. It is involving the entire superior hemisphere. So now, with the diagnosis of atypical lobular hyperplasia and the known strong family history of breast cancer, what is the right step forward? She's only 44. She has not even started her family yet. Okay. And she would like to know, what is the breast treatment plan? Should she undergo a mastectomy, or should we keep her under surveillance? What should be the proper management plan? If she undergoes a mastectomy, and all this is plain simple atypical lobular hyperplasia, is it a decision that has been justified? That is point one. And point two is, if she's under surveillance, remember guys, she's your baby. Like, as a radiologist, you are still under the scanner. Every time she undergoes a scan, she's going to ask you this question. Okay, is everything okay? And remember, if you or I were in this position, we have something which is called a high risk lesion. It is not potentially cancer. And somebody was asking us to get a mastectomy done at the age that we are in. Like, we are still young. Old is like many times my daughter says, yes, mama, are you young? I say, yes, I am young. I will be old when I turn 80 years old. Till then, I am young. Okay, but jokes apart, these are real life decisions for real life people. And we want to make the best possible decision for our patients. So what do? We go to literature and we find out what is the best possible option for this patient. Okay, so what is the first question that we have here?
So, ma'am, for our all our residents who have joined, and for all those budding radiologists interested in breast imaging, with the case scenario we came across till now, I would like you to please answer a few basic questions before we go to the actual literature review. Okay. So, what exactly is lobular carcinoma? Like DCIS, we all have been learning about and knowing about, but what is this entity of lobular carcinomas, ma'am?
Okay, so lobular carcinoma, under this, they encompass two things: atypical lobular hyperplasia and lobular carcinoma in situ. Okay, these are the two things that they put. Okay, how is it different from DCIS? DCIS typically involves tumor growth along the walls of the duct. Okay, but when we are talking lobular carcinoma, this is tumor growth inside the TDLU, terminal duct lobular unit. So if you think of the terminal duct lobular unit, think of a branch of a tree. You have a main stem, and then you have smaller stems, and then after that there are these leaves that are there. Think of the ductal system of the breast as such. There is the main duct, and from there smaller ducts which go out, and at the end of the ducts are these terminal duct lobular units. Okay, and within these terminal duct lobular units, there is proliferation of epithelial cells. So how do they differentiate between atypical lobular hyperplasia versus lobular carcinoma in situ? There are very subtle differences there. What they say is the number of distal lobules which are involved. So if there are only 2 or 3 terminal duct lobular units which are completely filled with tumor cells, then they call it atypical lobular hyperplasia. But if all those terminal duct lobular units are filled with tumor cells, plus they are dilated, distended as they call it, then they call it lobular carcinoma in situ. And this lobular carcinoma in situ also, they differentiate into 2 parts. One is classic and one is pleomorphic. As the name suggests, just like with microcalcifications, when we say pleomorphic, it is different sizes and shapes. Same, literally similar thing. Okay, we won't go into the pathologic nuances, but these are some basics about the pathologic nuances that we need to know as radiologists, and that is only what I'm explaining to you. If they are different pleomorphic, different sizes of those intraductal cells, then they call it pleomorphic LCS. If they are uniform, they call it classic LCIS. Why is this important? Because pleomorphic LCIS has a higher incidence of turning into a full-blown cancer. Okay, there are two schools of thoughts there. Atypical lobular hyperplasia is not a direct precursor of malignancy. For example, DCIS is a direct precursor of invasive breast cancer. The same way, atypical lobular hyperplasia is not considered a direct precursor of malignancy, but it is high risk. The presence of atypical lobular hyperplasia indicates that there is a higher risk that the woman may develop a cancer, just as radial scar by itself is not a cancerous lesion, but the associations. It is associated with atypical ductal hyperplasia, ADH, DCIS, and tubular carcinoma. Therefore, it is considered high risk. It is not a direct precursor of malignancy. Okay, वो खुद बुरा नहीं है, उसके दोस्त बुरे हैं. वो दोस्त बुरे दोस्त उसको बुरा बना देते हैं. Okay, it's the same way for ALH and LCIS. They are not direct precursors, but they are high risk. But the risk is not small. Okay, the risk ranges between 27% to 40%. Imagine if I was told that there is a 40% chance that you could eventually develop cancer, then I would be worried, because as an average risk woman, my risk for developing breast cancer is about 8 to 10%. Okay, that's all. Every woman, by virtue of being a woman, we all have that 8 to 10% lifetime risk of developing breast cancer. But does that mean we undergo mastectomies? No. Just because there are higher incidents of road traffic accidents on Western Express Highway, do we stop driving cars? No. We take all the adequate precautions and we do what we need to do. But here we are talking about risk of 27 to 40%. So how should we deal with it? And this is the question we are trying to answer. So we have selected two articles today for the discussion. Our decision-making factors for surgical excision or active surveillance. What should we do? Should we just keep her under observation, or should this woman undergo a mastectomy? What are people doing worldwide in cases such as this? Let's look at the literature. And with this thought in mind, we have selected two articles, and both these articles are from AJR. Okay, so I will share the first article here. Okay, Mitusha, can you see this article?
Yes, ma'am.
Surgical outcome of biopsy proven lobular neoplasia.
Yeah, ma'am, we can see
Yeah.
it.
Yeah. Is there any difference between lobular carcinoma in situ and atypical lobular hyperplasia? This was published in AJR in 2012. Okay, but I thought it was one of the better articles. And what they have done is they have looked at everything in this article. They have looked at all the biopsy proven LCIS and ALH. When we put LCIS and ALH together, we call it lobular neoplasia. Okay, and they try to assess the difference, between pure LCIS and pure ALH lesions regarding their radiologic presentation and the malignancy upgrade rate after surgical excision. And they also evaluated the outcome of the lesions that were not excised, but only followed up. What happened to those patients who decided not to have a mastectomy? Okay, and for the women who did not have a mastectomy or any surgical excision, they kept them under surveillance for about 2 years. Okay, 2 years is not a very long time, but long enough time to know that it did not grow into a full-blown cancer. Okay, and they also documented the upgrade rates. Okay, like we explained earlier, for microcalcifications. And coincidentally, most of these lesions are detected as microcalcifications on the mammogram, or they are incidental findings at the time of a biopsy. Okay. However, there are some articles out there that say that if you have done a core needle biopsy with a 14-gauge needle, and eventually the patient undergoes a surgical excision, then something that was ADH will become DCIS, something that was DCIS will become invasive cancer at the time of surgical excision. Okay, but this article says that whether they did the biopsy with a 14-gauge needle or whether they did the biopsy with a 10 gauge vacuum assisted device. They did not find a big upgrade rate when the patient underwent a surgical excision, or the upgrade rate was same for 14 gauge core needle biopsy as well as 10 gauge vacuum assisted biopsy. Okay, so coming to the results, what they found was cancer upgrade rate was documented in 17 of the 43 LCIS. Okay, means 40% of the women who underwent surgical excision, okay, for lobular carcinoma in situ had full-blown invasive lobular cancers. Okay, 11 of the 40 ALH, atypical lobular hyperplasia, which means 27%, had some kind of upgrade. So they either had DCIS, ductal carcinoma in situ, or invasive cancer. And 2 of the 6 combined ALH and LCIS lesions surgically excised for a total malignancy upgrade of 34%. Now, is that a risk factor we are willing to take? Okay, both LCIS and ALH lesions presented mammographically in most cases as microcalcifications, just as it was in our case. None of the patients followed up for the mean period of 51 months. Like, you know, the 14 patients, small number of patients decided not to undergo any surgical excision, but for that time period of 51 months, not they underwent a follow-up for a really long time, 3-4 years, and they did not develop any malignancy. So what is the conclusion? What is the conclusion of this author here? Okay, according to him, if you notice here, they are saying that when pure ALH lesion was the most aggressive lesion found on core needle biopsy, malignancy was documented after surgery in 27% cases, with no significant difference from LCIS, where 40% of the patient had malignancy. So according to this author, in absence of prospective randomized studies and evidence of factor predicting malignancy, the debate will continue as to the optimal management of these lobular neoplastic lesions on core needle biopsy. However, they conclude by saying the results of our study, in concert with the previous ones reported, prompt us to recommend surgery in all patients diagnosed with lobular neoplasia on core needle biopsy. That is the conclusion of this study, and they have looked at a fair number of lesions. Okay, they looked at a total of their biopsies, which was 14,435 core needle biopsies that were performed between 2004 to 2008, of which 126 patients had biopsy proven LCIS or ALH. Okay, and based on the 126 patients, they are concluding that their upgrade rate to some form of malignancy ranged between 27 to 40%. For LCIS, it was up to 40%, and for ALH, which was our patient, atypical lobular hyperplasia, it was 27%. And they are recommending that surgical excision be done. In our case, it would amount to a full mastectomy. Okay, so we were still not convinced that this is what we should offer to our patient. For a 27% risk, should she undergo mastectomy? Okay, so we reviewed one more article. And before I review that article, are there any comments that anybody from the audience would like to make? Any questions that you would like to ask me? Okay, Mitusha?
Ma'am, till now we have not received any specific question.
Okay.
I think we can start the review of the second one, and all of you who are listening, you can just post your queries in the chat box or the Q&A box. So it's like an active discussion we are looking at. So you can definitely, whatever your thought processes are, you can actually suggest also if you have a different opinion in this area.
Absolutely. So, so we will look at the second article now. Just as we were still thinking, given that our patient has a 27% risk of developing a full-blown cancer, should we ask for a mastectomy in this case? So we looked at this article. Mitusha, can you see it now?
Yes, ma'am.
Yeah. So this is also from AJR. And what they did was, and this article was published in November 2016. Okay. And it is titled Core Breast Biopsies Showing Lobular Carcinoma in situ should be excised and surveillance is reasonable for atypical lobular hyperplasia. So what they concluded from this study was LCI should be excised and ALH should be kept under surveillance. And to back their recommendation, what is the study they have done? Okay, so I'll read the objective here. The purpose of this article was to determine the upgrade rate to DCIS or invasive cancer at excision at the same site after percutaneous breast biopsy finding of atypical lobular hyperplasia or lobular carcinoma in situ using current imaging and strict pathologic criteria. But their study is quite robust also. Okay, they looked at all the biopsies from January 2006 to September 2013. A total of 32,960 core biopsies were performed, of which 1,084 core biopsies found ALH or LCIS. Remember, in the previous article, they had 126 core biopsies that showed ALH or LCIS. In this, it is 1,084. So literally 10 times more. Okay, so it gave us a little more confidence. For 447 lesions in 433 women, this was the only high-risk lesion at that site and no ipsilateral malignancy. So all we are dealing with here is ALH and LCIS. Okay, and what did their results show? Their results showed that among these 447 lesions, 22, which is 4.9%, were malignant at excision, including 10 invasive cancers. Okay, they were all node negative, and 12 DCIS. The upgrade rate of LCIS was 9.3%, and that of ALH was 3.5%. After excluding 5 cases with radiology pathology discordance and reclassifying one core from ALH to LCIS at review, the upgrade rate for LCIS remained higher than that for ALH. But having said that, it is still not that high in this study. And they concluded that excision is recommended for LCIS on core biopsy because of its 8.4 to 9.3% upgrade rate. Okay, now after reviewing 10 times more the number of lobular hyperplasias, this is the upgrade rate they have come up with, 9.3% for LCIS. Excluding the discordant case, patients with other high-risk lesions or concurrent malignancy, the risk of upgrade of ALH, atypical lobular hyperplasia, was about 2.4%. Surveillance at 6, 12, and 24 months can be performed in lieu of excision because a short delay in diagnosis of a few malignancies is not expected to cause harm. Okay, remember, the first thing that we have to remember is, as doctors, first do no harm. Hippocratic oath. That's the oath we took. We do not want to underdiagnose, but we do not want to overdiagnose also. Having said that, what did they conclude? This is a meta-analysis. They looked at everything that has been published in literature so far regarding ALH and LCIS. And after reviewing everything, they got these 1,084 cases. And of these 1,084 cases, they found that LCIS was the one that was upgrading more number of times than atypical lobular hyperplasia. Okay. However, remember, in our case, there was one exception as compared to regular LCIS and ALH. Okay, the exception was her personal history. Okay, in this article also, in the end, they have mentioned to us that in conclusion, the upgrade rate to malignancy at excision was statistically significantly higher after a concordant core biopsy diagnosis of LCIS. Okay, women between 40 and 59 years of years old have particularly low upgrade rates. Younger women will have a lower upgrade rate, is what they're saying. Lobular neoplasia lesions in women with a family history of breast or ovarian cancer were more likely to be upgraded. Even in this article, although they are saying that atypical lobular hyperplasias can be kept under surveillance, they are warning us that women who have a family history of breast or ovarian cancer are more likely to be upgraded. So even if they are saying that in our case, there is a 3.5% upgrade rate from ALH to a full-blown cancer, our patient, there is a potential chance that she could fall into this category simply because of her strong family history. But they also warn us that the upgrade rate was not statistically significant in the subset of women with suspicious calcifications. Calcifications was the predominant finding in all these cases. Okay, so how do we conclude in these cases? We continue to recommend excision after a finding of ALH at biopsy of non-calcified lesions, because ALH is not expected to produce such a finding on imaging. So in our case, there are two findings that favor that the patient should have excision. It is her strong family history. And in addition to microcalcifications, she also had a mass. So in this article, after reviewing 1,084 lesions, which included LCIS and ALH, they concluded that LCIS has a higher upgrade rate than ALH. But if ALH is associated not just with microcalcification, but also with a mass, and if the woman has a family history of breast or ovarian cancer, then automatically her risk of upgrade increases. So based on these two articles, we conclude that our patient in this situation should definitely have this discussion about having a mastectomy than being under surveillance. But remember, these are controversial lesions and every case has to be treated case-based. Everything has to be accounted for before a big decision like a mastectomy is done for our patients. So with that, I conclude discussion of these two papers, and I open the and I would request Mitusha to open the forum for discussion, for questions. If anybody has questions, or if Mitusha, you have some questions.
So ma'am, people have not yet started posting their questions,
Yeah.
but I think they will soon do it. So just a few things like, is it there any role of like prophylactic bilateral mastectomies, or only unilateral will be suggested, ma'am, for this patient?
There is one more thing that would have to be done before we offer any kind of mastectomy to this patient, and that would be genetic mutation testing. Okay, that is one missing link in this whole thing. You know, given her strong family history plus her diagnosis of a high-risk lesion, she definitely needs to have BRCA mutation testing, the whole panel. Okay, and if she is BRCA1 or BRCA2 mutation positive, then the entire thing changes. Then the decision becomes easier. But if she is BRCA mutation negative, she does not have a genetic predilection for having for being high risk in that regard, then maybe we could still have a discussion with her about surveillance.
Okay. So if it is BRCA positive, mutations are positive, then will it be like bilateral mastectomies for?
That would definitely be a consideration, because BRCA1 mutation carriers have a 89% lifetime risk of developing breast cancer. So like I said, an average risk woman has 8 to 9% lifetime risk of developing breast cancer. A BRCA1 mutation carrier has 89% lifetime risk. A BRCA2 mutation carrier has a 50% lifetime risk. In our patient, she also has a high-risk lesion, which is multicentric. Okay, so that makes her risk even higher. With the strong family history, high-risk lesion, BRCA mutation carrier, then it is a no-brainer. Then it should be bilateral mastectomies with reconstruction.
Okay. So thank you for that. Also, ma'am, as a radiologist, is there any role of PET CT scan, because we have done MRI, everything for her. So is there any role of PET CT as a further investigation modality anywhere?
No, not for these precursor lesions. PET CTs are usually done for staging of invasive cancer. Now, this was not even a full-blown cancer at the time of diagnosis. It was just a precursor lesion. So PET CT has no role to play in cases like this.
Okay, ma'am. So no need of further like staging it like whole body extent or anything, just
No,
like
not
even
at all.
not as a baseline study.
Yes, not at all. Like this is not an invasive cancer. So there is no question of this spreading to any other parts of the body.
Right.
Yeah.
And one more thing, like there was a radiology and pathology discordance in this particular case, because on ultrasound it was looking more invasive as compared to it just turned out to be in situ and lobular part ALH. So do you think, ma'am, any repeat biopsy just to remove the sampling bias is required, or is it we are sure that it is just like ALH and not invasive?
Yeah. So here is the thing, considering that this is a big decision for the patient undergoing a mastectomy for a precursor lesion, like, you know, for not a precursor, but a high risk lesion, then we could consider repeating the biopsy with a bigger needle, like a 10 gauge vacuum assisted biopsy before subjecting the patient to complete mastectomy. But having said that, most of the articles out there, most of the literature review is telling us that they did not find a statistically significant difference between a 14 gauge core needle biopsy versus a 10 gauge vacuum assisted biopsy when it came to upgrade rates. There must be a few cases, but you know, as they say, a few swallows don't make a summer. Like, you know, only if you see a few cases, it does not mean that is the rule. Okay, so therefore, but having said that, you know, in a case such as this, I would definitely entertain the idea of doing a vacuum assisted biopsy before subjecting the patient to a mastectomy.
Thank you for that, ma'am. Just one more question.
Yes.
Like for this patient, we did like mammography and then MRI. Biopsy was done earlier before the MRI.
Yeah.
So if you have any suspicious like area in or ultrasound and mammography, should we go for MRI first? And then if possible, MR guided biopsies, or like just planning it and after doing MRI, so we have a better guidance for the sampling area. So anything like that, ma'am?
Very, very good question. So here is the thing. It is always the temptation. Should I do an MRI first? But if you're seeing clear-cut findings, like you were seeing in this case, there were pleomorphic microcalcifications, there was a suspicious mass. In this case, you don't need an MRI to come to a diagnosis. What you need is a biopsy. What you need is a tissue diagnosis. So first is always biopsy. And after the biopsy, to look for the extent of disease, perhaps, we can do an MRI. Okay, or to look for contralateral malignancy, if there is a dense breast, then we can do an MRI. And in that case, it may prompt us to do a second look ultrasound or a second biopsy of another lesion, perhaps. That is a possibility. But a MRI will never replace tissue diagnosis.
Okay, ma'am. So that definitely helps, because we get confused in various situations.
Right.
And as radiologists, patient are like looking towards us to guide them further.
Correct. Absolutely.
What should we do next? This is their question.
Right.
So just taking it further, ma'am, suppose for this case, we decided on mastectomy for this particular patient. But if for the situation provided, if we decide for active surveillance, not for this patient, but for some other patient, then how much should be the frequency? What should be the frequency of that like repeat scans, and it should be mammo plus sono or only sono? How should it be done, ma'am?
Oh, well, this would need a very active surveillance like high risk screening. As part of high risk screening, the surveillance protocol is every 6 months, she's under some form of surveillance. So if she has a mammogram and breast ultrasound in January, then she will have a contrast enhanced breast MRI in June. Okay, then again, if everything is stable, both on the mammogram that was performed in January and on the MRI that was performed in June, as compared to the previous mammogram and MRI, then she goes back to the next year, same protocol. Every 6 months, alternating every 6 months, mammogram once, MRI once. That is the surveillance protocol.
Thank you, ma'am. One more question. Is there a role of contrast enhanced mammography in these cases, ma'am?
Yeah, that is currently being evaluated. Can contrast enhanced mammography be used as a screening tool for younger women? The answer still remains to be found. As more and more literature comes out, we will know. Also, with MRI, there is no radiation involved. And these are high-risk women who are much younger. Screening protocols start for them in their 30s. Therefore, it is very important to be cognizant of the fact that there is a fair amount of radiation involved with doing a mammogram plus a contrast enhanced mammography. So I think the logical answer here is it is better to do a contrast enhanced MRI for surveillance rather than doing a contrast enhanced mammography. But it remains to be seen. As more and more literature gets published, we will know better.
Thank you, ma'am, for taking all those questions. In the chat box, I couldn't find any further questions, but people are putting in positive feedback.
Excellent.
And I think the discussion helped all of us to come across the doubts we had and come across with the solutions to them as well.
Yes. So thank you very much, Mitusha, for taking us through this entire session. And thank you, Gayatri, for volunteering to take this case. Thank you, Gauri, for being in the background and doing all the nitty-gritties in management. And of course, without Dr. Patkar sir and without Dr. Mani sir, we can't execute this. And then Dr. Shailendra Singh and Jignesh Thakkar. So thank you, everyone. We look forward to feedback from all our participants about did you like the format? How would you like us to improvise? And what would you like us to do differently? It is your feedback that helps us do things better and differently. At the end of the day, we are all learning, and we are here to learn from you, and we are here to be involved in the teaching. So thank you to all those who were participating on a Sunday morning, taking the time off from their families. Thank you, everyone.
Thank you, everyone. And stay tuned for the upcoming journal clubs. This is a monthly event we are planning, and we'll be taking about neuroimaging, breast imaging, body imaging, oncoimaging, and musculoskeletal imaging. Every month, one topic at a time. We are going to share these articles with you on a Google Drive link so that you can review them later as well. And the next journal club will be pertaining to body oncoimaging. So please stay tuned, and the post will be put on various social media platforms as well as on our channel. And this also will be shared on the YouTube channel of Indian Radiologists. So please do subscribe for the same. Thank you once again for your support, and thank you, Bears, for your kind support for this academic event. So with this, we come to an end of the session for today. Thank you all for your positive feedbacks. We also require your feedbacks how to improvise about it. So we welcome you for that as well. And stay safe, stay connected. Thank you all.